Welcome everybody to this NPA Making Your Pharmacy First Work for Your Business webinar. Thank you so much for joining us this evening on this very cold evening and taking time out. We've got a lovely selection of people to come and help you with trying tackling those issues that you're all struggling with and trying to navigate in our busy community pharmacies. And I think it's really important that we try to support you and try and get you on the right track to really get this pharmacy first service running really smoothly within your community setting. And that means empowering your teams, that means empowering yourself so that you can apply the knowledge that, trust me, you all actually do have, but actually applying it in a way that you can be more efficient and actually gain some insight and profitability in your business for the knowledge you already have. I'm always banging on about the fact that we are competent professionals, but we need to be able to display that in a way that portrays that. So I'm very honoured to host this webinar today. That's been very kindly sponsored by our two sponsors, Timper Health and Skills for Pharmacy. So joining us from Skills for Pharmacy is Ankit. Ankit, if you'd like to say hello.
Hello, everyone.
So that's from Skills for Pharmacy. And then we've got Helen, who's joined us from Timper Health. Welcome, Helen.
Hi, nice to be here.
Perfect, excellent. So I suppose I need to do the real introduction for Darshan. Darshan is our expert that's going to come and join us today and give you most of the information that you will ever need to make your pharmacy first run really efficiently. Darshan is part of the GP Pharmacist Limited organization, which really trains and is dedicated towards giving you those clinical skill sets and competency that you really need. So I think it's really important that we appreciate the fact that we are being taught by someone, and I genuinely say that I've had the experience of being taught by Darshan, and he is so knowledgeable. Everyone, try and get as many nuggets, golden nuggets as you possibly can, and you'll be very surprised where these nuggets will apply to you when you're in your day-to-day. And it's very difficult when you're sifting through so much information to try and see what's actually practical. And I think the beauty of what Darshan is able to sort of share with us today is how to apply that practically in every sense of the word. So I shall hand it over to you, Darshan.
Wonderful. Thank you so much, Suki. You've been absolutely amazing, and I'm so honored, and I'm really, really pleased that yourself and Helen and the NPA team have allowed me to talk to your colleagues today. Before we kick off, we got our sponsors, and we're going to be having a bit of a session with our sponsors so that you guys can actually see what value you can bring to your pharmacy, to your businesses, and to your service provision. So I think we got Ankit first, okay? Ankit, if you kindly unmute yourself, and I'll be your slide shifter, okay? So just tell me next slide, please, and I'll do my bit.
Hello, everyone. Thank you for being here. My name is Ankit. I'm the account manager at Skills for Pharmacy, the apprenticeship training provider. Next, please. Next slide. Yes, a little bit about us. We're one of the largest providers of education in the pharmacy sector, cover across all England, over 1,000 learners, and a team of 35 plus tutors. It's a tutor-led delivery system. Everything is done online. There's flexibility of delivery. The main focus point which differentiates us from our competitors is the quality of delivery. I mean, for example, we are one of 21 providers within the country, and the recent PTPD fundings, we've secured 220 places out of the 530 possible. So that's over 50% placements gone to Skills for. Next, please. Yep, industry challenge. We tackle to the pharmacy industry with how it's evolving rapidly to skilled and adaptive workers. There is a workforce gap. Many pharmacies struggle to find qualified staff. We could help you with that with our talent acquisition team. And also we work with the costs and staff wages. Next, please. Yep, apprenticeships next. So what is an apprenticeship within the pharmacy? It's a work-based learning program combined with practical training and on-the-job training. New and existing learners can go on it. We sort of help you find the right candidates for you, or you could enroll the learners who are in situ, who are currently working for you. Allocated minimum of 6 hours of the job training, which includes the 2 hours online sessions every week, depending on level 2 or level 3. Next, please. Yep, so the wages for the apprentices would start at £6.40, and depending on if the candidate is suitable for you, you could just always incentivize to attract that candidate towards your pharmacy with maybe increase in pay, maybe £7 or £7.40. And the remaining is government funded. So the whole course, depending on level 2 or level 3, the level 2 pharmacy service assistant is £5,000 for the course, and the level 3 would be £8,000. And 95% of it is funded by the government. But again, for non-levy employers, which is majority of the independent pharmacies, ages from 16 to 21, everything is covered by the government. Plus, there is also an incentive of £1,000 every pharmacy, every apprentice which you take on board. Next, please. Yep, developing skills in healthcare. Like I just mentioned, level 2 pharmacy assistant apprenticeship, level 3 pharmacy technician, and we also have a level 3 team leader apprenticeship, which is a new course which revolves around training your existing staff members who are either level 2 or level 3 to have another accolade on their CV as well. Next, please. Yep, here's a breakdown of level 2 pharmacy assistant. It's a 12-month course plus 3 months endpoint assessment. We do monthly enrollments with our tutors, regulatory requirements. We are also working hand to hand with GPHC because it's GPHC accredited, and we have Ofsted certified as well. Yep, next, please. Level 3 pharmacy technician. Again, this apprenticeship training is covered throughout 24 months period. We have weekly sessions. Level 2 has bi-weekly sessions online, and level 3 has weekly sessions, which require the candidate to join online every week for 2 hours, depending on the schedule and the class. Pharmacy technician, of course, comes with the ACT training, which is accuracy checking, which helps a lot of pharmacies, as you all know. Yep, next, please. So, like I mentioned before, PTPT fundings, they had been the results which were out a couple of weeks ago, and out of the 530 possible slots, we managed to bag 220. As in 220 pharmacies who have managed to secure the funding are being enrolled with us. Yeah, next, please. So, yeah, skills for pharmacy recruitment process. So this is for the pharmacies who are currently looking for apprentices. We have a very good talent pool. We have an incredible talent acquisition team who are constantly looking for candidates. We screen them for you so that you don't have to worry about whether if it's the right fit. And once you get the final interview, you get the shortlist, and you don't have to take the candidate on board. You can always say no, and we look for another candidate for you. Next, please. Yeah, this is our recruitment platform. We work with Just Apply, Indeed, Google Jobs, government apprentice website, the National Apprentice Service. We have Bootcamp and also Read. Yeah, work with Read. Yeah, next, please. A little bit about Bootcamp. Bootcamp is a 10-week voluntary training which preps the candidates for level 3 straight. That means the candidates look for this opportunity and they are enrolled on it, and they take their time out to be enrolled on this, just so that pharmacies don't have to worry about their previous experiences for level 3, and they can straight be enrolled on level 3. We currently have various regions across the UK who have successful boot campers ready to be onboarded on retainer. Next, please. Yeah, like I said, the current bootcamp region, Oxford, Devon, Lancashire, Leicester City, Liverpool, Cheshire, Warrington, and Greater London, and North East as well. Next, please. Yeah, where do our learners come from? Like I mentioned before, our learners majority of them are passionately out seeking for the apprenticeship roles. They approach us to read job centers and the UK career fairs, and then we sort of shortlist them, we screen them, and then we branch them out to the pharmacies. Next, please. Yeah, why hire through Skills Bootcamp? Like I said before, they go through a vigorous 10-week training procedures, which prep them for level 3, and they will be very hands-on compared to a person who is jumping into level 3 without any past experience. Yeah, next, please. Yeah, I've done that. Next, please. Yeah. Yeah, Skills for Pharmacy already works with several big companies such as Wellriggs, Day Lewis Pharmacy, NHS, England, Superdrug, Cohen's, and yeah, Camson Pharmacy. So there's just some of the names here which we already have big accounts with. Yeah, next, please. Yeah, I think that would wrap up my session for the day. If you have any questions, feel free to pop in the chat. I'll try and reply to them as much as I can. Thank you.
Amazing, Ankar. Thank you so much. And thank you really for showing how we can improve capacity. Okay, homegrown individuals, especially in the new dawn of things, how things are going to work. I think it's absolutely wonderful. And thank you for doing what you're doing. Of course, any questions regarding this in terms of how you can implement it, Ankar, maybe put your details down on chat so people can actually reach out. But if you've got any questions specifically, Ankar will keep an eye out on that. And there's your details already there, but maybe put it on chat anyway. Okay. Thank you again, Ankar. Fantastic. Now we've got the wonderful Helen from Timper Health.
Thank you, Darshan. Yeah, so my name's Helen Thompson-Parry. I'm one of the key account directors at Timper Health Technologies. I've worked for Timper for about 4.5 years now, audiologist by background. So just obviously today we have just over 5 minutes to give you a brief summary of how Timper can really support you and your pharmacy to successfully deliver ear and hearing health services. But ideally, we need about 20-30 minutes to go through everything in more detail. So I'll pop my details in the chat and feel free to email me if you want to know more details about what I talk about now. Next slide, please. So our CEO and founder, Dr. Krishan Ramdev, developed Timper about 7-8 years ago now, and it was when he was on the NHS entrepreneurial program. He realised that the ear and hearing healthcare pathway was very disjointed, and he felt that with the right training, the right skills, the right support, that allied healthcare professionals could safely deliver ear and hearing health care, triage patients within primary care, and then obviously improve the efficiency of that ear and hearing healthcare pathway. So we went about developing the Timper system. Since then, obviously, COVID has happened and a lot of GPs have pulled away from the provision of any earwax removal services. Very few GPs now offer earwax removal services. And quite rightly, obviously, previously, that used to be irrigation was the method that was commonly used within GP practice, and that's a little bit of an old-fashioned method now. We prefer microsuction, which is the safer method. So that's what we train, and there's a lot less risks involved with the microsuction procedure. Next slide, please. So Timper does everything you need for an ear and hearing health service. We're not just a microsuction. We don't just train you on microsuction. Our course is an accredited otoscopy training course, plus the microsuction to be able to remove any wax if it's present. So it allows you to take a full case history, the patient sign, check for any contraindications, the patient signs on the TIMPA, so there's no paperwork, everything is digitalized. Next slide, please. It's the visualization tool that you use for the procedure. And I know Darshan is going to go on to talk about Pharmacy First, but all our TIMPA clinicians who are offering Pharmacy First for acute otitis media for 1 to 17-year-olds really prefer to use their TIMPA when looking in ears, because the magnification is 9.2 as opposed to 4.2, which is your standard otoscope. So what you can see is far, far superior. You can zoom, you can focus, you can change the white light balance, you can take high definition videos, you can take images, so you can ask for advice and guidance from a team of experts, including ENT, if you're not sure. You can download all this data and you can share it remotely with GP if that needs to then be referred on to GP, and they can view the images on a safe and secure digital streaming site. So it's far superior. I actually spoke to a pharmacist earlier today and she was like, how do my local pharmacists use the TIMPA when they come into the store? And I'm like, well, they haven't gone through the training, so they can't. They'll have to use the standard otoscope. She's like, but the image quality is not as good. They can't possibly see as well. And I'm like, no. And as an audiologist, when I try and look with a standard otoscope now, it's not as good at all. And next slide, please. So yeah, obviously I briefly touched on it. Microsuction, gentle suction probe. Advised to soften the wax for 2-3 days before the procedure, which is very different to the irrigation, which was about 2 weeks of using olive oil. And by the way, putting olive oil into a very, 80-90% blocked ear with wax, it just absorbs into the wax. The hearing gets even worse temporarily, and then it becomes a big gooey mess. So 2 to 3 days, then they come back, you gently either tease it out and it comes out as a wax plug, or it sucks up the tube. You're not applying any pressure to the eardrum and you're not leaving the ear wet. So the risk of post-treatment infections is a lot lower as well. Next slide, please. Again, we're about ear and hearing health, and that's what really sets us apart from some other providers out there. So we are, there's about 6 million people in the UK with some weakness in their hearing, and only about 2 million people actually wear hearing aids. That's because on average people wait 7 years before they take action on a hearing loss. So it's about educating the general public that there is a weakness with their hearing, and then through the TIMPA platform from early new year, you'll actually be able to refer patients on for full diagnostic audiometry with a private provider. We will facilitate that for you as well, so you can offer a 360 approach there. But it's one of the biggest modifiable risk factors to treat an untreated hearing loss for cognitive decline and dementia. So it's about educating people and taking action sooner to help their hearing and keep their well-being and social interactions. Next slide, please. This is what really sets us apart as well. All the clinicians that we train, as I said, they go through the accredited otoscopy course, so they're very familiar with all the landmarks on the tympanic membrane. They know what looks normal and what isn't normal. If they identify any potential abnormality, they have a team of experts in the background that they can ask a second medical opinion for advice and guidance. So through our TIMPA cloud, where all your data is stored, with the click of 2 buttons, you can request a remote review. Our team of audiologists look at it within the first 24 hours. If they're not sure, they escalate it to our ENT, and that takes 5 working days. And I'm sure Darshan will agree, if he got a referral with ENT comments on what the appropriate treatment plan, that'd be a wonderful thing to get. So this is about how we're really improving the ear care pathway and triaging very effectively in community settings. Next slide, please. So as I said, your data is incredibly secure. So we're DTAC compliant. We work with the NHS. We work with very large multiple national companies. We go through a lot of data security to make sure all your data is safe and secure. If you have multiple stores, you can basically view the data over those multiple stores. We can pull data analytics for you to help you if anybody needs. We also have a professional services department if you need any advice and guidance around the professional services. We have patient information leaflets, we have marketing support for you. So we've also got private PGDs that are coming in the new year to really truly help you to deliver ear and hearing health services. And what we find is a lot of people that come in thinking they've got an ear infection, it's just blocked with wax. So by offering ear health, checking the ear health, you'll probably be driving opportunity to your earwax removal service as well. It depends how you deliver it as to how much revenue. If you have one person deliver it over multiple sites or full time, obviously you can make incredible revenue. If you train a technician or dispenser to deliver the bulk of the appointments and your pharmacist to do the ear health clinics, you'll typically do about 5-10 appointments a week. The average cost for microsuction wax removal is £60-70, but then you've got your over-the-counter items like your ear roll. You've obviously, you can even use a private PG at the moment. There is one out there for Optimize, which is common, because Pharmacy First doesn't do that. It doesn't do outer ear infections. It's very limited to 1 to 17 for children. And I'm sure you will get a lot of adults coming in thinking that you can look in adults' ears and prescribe for that. So, yeah. Next slide, please. We're very proud of our training program. We do, as I said, it's an accredited otoscopy training course. We don't believe in training anybody in microsuction earwax removal if they haven't completed an accredited otoscopy training course. We want our timber providers to know what they're looking at and be confident when they're looking in the ears. It's a blended approach. They do 8 modules online. They do a group training face-to-face, which is 90% practical at that group training event. They have to then be observed removing wax safely and competently from 4 ears, and then they're signed off to work autonomously. But we do offer hints and tips webinars, and we constantly share any changes in advice and guidance and so on. Why timber? Hopefully I've explained why timber. Next slide, please. We do everything. It's basically a subscription model, but you basically get everything you need to deliver a successful ear and hearing health and wax removal service. If any of the equipment becomes faulty, this is really important. You don't have to send it away for repair, or there's additional cost for repair. We replace it the next day. If we can't resolve the issue over the phone with our customer support team, they get a new kit out to you, so you don't have any lost clinics or anything like that. Thank you. I'll pop my email in the chat, and I'm sure you'll get my details afterwards as well. But thank you so much for listening.
Helen, I have a dream. Okay, and I'll tell you what my dream is. Okay, see, this is the kind of stuff in terms of expanding the scope of practice, expanding the revenue generated for our services in the community. People are coming into our pharmacies anyway because they know we've got that otoscopy. They know we're going to be checking people's ears, because it says, they don't really look at the fine print of, age range or whatever. They just say, oh, can you check into my ears? And if we can get people in to actually address their ear health and the fact that they might have wax, they're going to have to get it somewhere, and they could go to an audiologist, but there are not many around in the community. GPs aren't bothered to do it because they're not being funded. So who's going to look after your ear health and wax? I think, this is a no-brainer.
Yeah. I mean, typically our clinicians are delivering about 30,000 wax removal appointments a month at the moment. Amazing. Where would those appointments be seen if the pharmacies out there weren't delivering that service? It's invaluable that community pharmacy offer this service, and then they can offer the whole package by actually the ear health as well. And then obviously with the hearing check, it's really exciting, the future, absolutely.
And what I really like, because look, in my PCN, I work in Southwest London. My pharmacy next to me is Pearl Pharmacy. You know the guys. Yeah. So Mike and the team, right? And we referred our patients onto them, and they were able to get advice and guidance simply by attaching it and sending it on to an ENT specialist, who basically said, boom, 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 this is what needs to be done. We're going to write a letter to the GP. It's a closed loop system.
Mm-hmm. Yeah.
So, thank you so much. I hope please put your details into the chat so colleagues can contact you directly. But also, if there's anyone who's got questions, please type it onto the chat so that Helen can address it directly to meet your needs. Because if it's your question, it could be someone else's question as well. Thank you both, Ankath and Helen. Thank you.
Darshan, there was a question actually. I don't know
Ah.
whether Helen is able to answer it. It was from Mahesh, and it was, who does the data belong to in the event that you terminate the service with Timber Health? Which I think is quite a valid question.
Yeah, you own the data. We're the data. You're the data owner and controller. We just process the data for you. So if you terminated the contract with Timber, we will give you the data in whatever format that you want.
Okay, brilliant. Okay, thank you.
Fantastic. Thank you so much. And thank you so much for our wonderful sponsors. You guys are awesome, changing the shape of community pharmacy. So, ladies and gents, boys and girls, welcome. My name's Darshan Gandhi, and I'm a PCN pharmacist. I've also got a community pharmacy, but my passion for fashion, well, it's not really for fashion, it's mainly for pharmacy and education and trying to upskill our colleagues so we can do the best we can for our colleagues, for our patients coming into our practices. And, you know, times are changing. You know, the focus is very much on preventative. And see, the idea is if we can get pharmacy first right, and I'm sure, Suki, you'd advocate towards this, if we can get pharmacy first right and we can show that, look, you know what, this is a no-brainer, then if we can give out antibiotics, surely we can give out the blue, the brown inhaler, we can give out HRT, we can give out medications for prevention of hip fractures. You know, the world is our oyster, and we've got to really be in it to win it. And as long as we've got our fundamentals sorted, our fundamental sort of consultations, we can use it and adapt and adopt it for whatever circumstance we come about. Suki, what's your forward view? Like, you know, I know we've got a 10-year forward view that's happening with pharmacy and healthcare and primary care. What do you feel is the direction of change?
I think we need to be very proud of being community pharmacists and proud of what we are able to offer already. And I think it's really giving ourselves a platform. We've always been a very humble profession, and we think that everything we are doing is just normal. Well, actually, if we weren't there, and if community pharmacies weren't available to the general public and their local communities, that would be such a big gap that wouldn't be filled by anyone else. And it's such a unique selling point in terms of our expertise. You've got trained clinicians that are available to the general public by walking in. And in this day and age, post-COVID, I think, you know, we mustn't underestimate that power and that accessibility. So we should be really showcasing who we are. Don't be shy, I would say, as a sector. Come on, let's get out there. Let's show what we can do. We can all do this. It's just making every contact count, because then one person will mention to their friend in the coffee shop saying, well, actually, I didn't have to wait 2 weeks for my appointment. I just went in and saw my pharmacist. Darshan was able to sort it out. Darshan checked my ears. I didn't realize that I had lost so much hearing, or whatever it is. You know, as community pharmacists, we know our community. So I think there's so much scope that we should really be showcasing that as much as possible. And they want evidence. And this is an ideal way to show that evidence.
Absolutely. And they're getting that data. I mean, like we're seeing it on chemists and druggists. We're seeing the league tables of how many encounters, how many engagements are being done. And I think, you know, ladies and gents, you know, please take the impact and the shift of change in our environment seriously, because, you know, forget about the price of amlodipine, forget the price of candesartan and all that stuff, because this is not going to be sustainable going forward. You know, we've got Amazon knocking on our door. We got, you know, the online pharmacy sectors trying to, you know, grab and pinch the businesses. So we've got to utilize the strengths of being present in the community to basically demonstrate that we can provide services, not have a faceless pharmacy, but have a forward-facing pharmacy where individuals can get health advice, you know, guidance, support, and also signposting to the appropriate services to keep them healthy at home. So, ladies and gents, it brings me great pleasure to talk to you today about how can we get the best out of pharmacy first, to make it work for you, to make it work for your business, to make it work for your communities, but also to make it work for your profession at large, because this is the time where pharmacy is going to really take center stage. Okay. Now, I mentioned earlier, and I was speaking to Helen from NPA and Suki. They call me the machine gun. They call me the machine gun. They call me a machine gun because I speak at almost like 100 miles an hour. So thankfully, this is being recorded. But what I would say is, please keep your pens and papers ready. Okay, top tips, pertinent points. Do jot it down. All right. If you have any questions, please jot it down onto the actual chat function. Okay, and where at the end of that particular section, I'll say, Suki, are there any questions pertaining to that particular topic? And then we can have that same sort of theme going forward. Okay, I've also got a lot of questions and a lot of quizzes. It's going to be super interactive where I want you to, jot your answers down as you can. Fastest finger first, like catchphrase. Okay, you see Mr. Chips, what's Mr. Chips doing? Da, da, da. I want you to write it down. Fastest finger first, okay? And what I'm going to be going over is, yes, the stuff that you might have already come across in previous sessions with the NPA and GP pharmacists, but also how can we engage and increase that sort of GP referrals. And this is something which is I've bespoke it just for you guys this evening, tonight. Okay. So again, massive thank you for our sponsors and NPA for allowing me to be present today and to give you what I've considered maybe hopefully some good tips. I've mentioned I'm a PCN pharmacist. I have also got in collaboration with my wonderful partner Sanjay, Lewisham Pharmacy in Southeast London. But really my sort of like passion is education training. I'm a CPP events tutor for London under Michelle. I also work for Morph Training under Rachel, and also a GP pharmacist, just as a passion for delivery. And really what I've been focusing on is training colleagues like yourselves, pharmacists, pharmacy professionals, to engage and encounter and expand your scope of practice and experience and expertise on both long-term conditions and really doubling down on pharmacy first going forward. Okay, so I hope that's something that you are subscribed to and that you will be happy to engage with me today. What I'm going to be really talking about from today is GP referrals, looking at top tips, consultation skills. Then we'll be looking at the 7 sections of the clinical pathways, top tips in terms of the case studies, in terms of what are we trying to look for, and any particular potential red flag scenarios that I've encountered, I've seen both in community as well as in primary care that would be pertinent for yourselves. Finished off like we do in all Christmas spirit, a quiz. Okay, so I hope that's something that you're happy to think about. Okay, and I'll leave you a moment just to have a read of the learning outcomes. Okay, so this is what I'm hoping that you're going to take away. If there is anything particular that you're looking for, do jot it down. Suki, if you can just keep a mental note of it, that, if we haven't addressed it, we can then, of course, come back to it and we can address it specifically. But this is what my learning outcomes for you will be going forward. Okay. So what are we going to kick off with? Well, we're going to kick off with what is the pharmacy first. And I'm not going to teach grandma to suck eggs here. Okay. That sentence almost went very wrong, but no, I'm not going to teach grandma to suck eggs here. So as we know, advanced service, an evolution from CPCF, okay, and it basically enables pharmacists and pharmacy teams to provide that advice and support for NHS-funded treatment where appropriate for those 7 common conditions, okay? And we know from these clinical pathways, it gives us a structure, a real nice sort of guidelines and framework from which whom we can engage with in terms of our inclusion criteria, but also looking at the exclusion criteria based on the PGTs of what patients are appropriate to take depending on their therapies and treatments, okay? But I know there's an issue and I know there's a concern at the moment. And I've recently got a new role in my area in Merton as a PCN engagement lead for Pharmacy First, trying to bridge this gap between our community pharmacies and PCNs and surgeries as to why are we not getting the necessary referrals. And I've been in post for the last couple of weeks, and I'm just going to show you some top tips that I've actually learned from whilst engaging with my colleagues in GP surgeries and PCNs. And I think this is something that you might find, yeah, this is quite synonymous. So they found that because sometimes we get a little locums, okay, maybe more towards the multiples compared to single or unit owner pharmacies, but sometimes it's not picked up in a timely manner, and maybe individuals are not able to check or not knowing that they need to check their farm outcomes requirements on a regular basis, okay? And as a result, this kind of puts people off. This puts the surgeries off, puts the GPs off, puts the practice managers off as well, okay? Another thing that I found from my conversations is that surgeries obviously having a massive sort of influx of trainees coming in and out, okay? Suki, okay? Yep, good. Yeah, trainees are coming in and out, and GP trainees do not know the system. They don't know pharmacy first. So it's almost like having to train them and teach them. And you might think, oh, yeah, of course we've got all these people coming in. How am I supposed to engage everyone? But I think that also shows an opportunity for our teams in community pharmacy land to be able to say, who's your new trainees that are coming through your surgeries? Let me have like half a day, let them come to the pharmacy, spend some time with me in the community pharmacy. And that's what I've done in my pharmacy in Lewisham. And that's what I implore you guys to do as well. So that could be something which would be a good thing to do. Of course, we mentioned about locums. Sometimes they don't provide the service. Sometimes, if you're unwell or if you're on holiday as a business operator or the manager for that premises, and you get someone in because obviously you need someone to carrying on business, but the agencies also may not provide the individuals who are able to use the system or in terms of accessing farm outcomes, or may not be able to provide the services for pharmacy first because of either lack of competence or lack of confidence as well. So I think if you're engaging with your locum agencies, please do try to find out more who you're going to be sent. Are they able to provide the service, and are they able to confidently update the information on farm outcomes or the other systems that you might have? We have also found that GP staff don't always have the right training in order to identify the patients who might benefit from your services. So that's something which I'll show you. One of the things that I've been doing, with all the reception teams that I've been meeting in the different PCNs that I'm working doing this piece of work for, is trying to engage new members of staff, but also visiting once a quarter or so. How's everything going, guys? Are you still happy? Is there any questions about pharmacy first? Anything I can help support you to identify those right people that I can help reduce the issues from your side. So happy to do that, to make sure you have that engagement. I've also found that GP practices don't always have the details of the service, and that obviously comes down to that engagement piece between yourself and your associated GP practice, where you get the majority of your prescription for. Finally, there's also a need to ensure that individuals that answer the sort of calls at the reception desk are able to triage individuals, utilize the GPIT systems to help go identify patients who would benefit, because there's no point, a man calling up, oh, I think I've got a UTI and I've got a catheter, and the reception saying, oh, UTI, oh yeah, surely the pharmacist can do that. Let's send this person over. Obviously, because it's a gentleman and because the person's on a catheter, it excludes that individual altogether. So you need to make sure that they have a basic understanding of the inclusion and exclusion criteria, and utilize the GP systems that they've got, either System 1 or EMIS system, in order to navigate that individual appropriately. Last thing you want to do is annoy the patient by inappropriate referrals from the GP to the pharmacy, having to boomerang back into the GP practice because the pharmacy can't do it, either because of confidence, competence, lack of training, or the fact that the patient isn't appropriate for that, inappropriate for that particular provision of service. So we need to get it right, and get it right from that engagement. Now, it would be really interesting to find out if you can say, do you guys engage with your GP practice? Are you active in your engagement? I know sometimes it's busy, okay? And I know sometimes you think, you know what, Community Pharmacy England are providing all this training, education and all that sort of materials. They can do that sort of engagement bit. But ultimately, it's not community pharmacy that's putting money in your pocket. It's not community pharmacy that's bringing patients in. It's your relationship that you need to build. And I think that's where Community Pharmacy England, although they got fantastic resources, they're only as good as how they're utilized by that community pharmacy team when they're using it with their patients, the public, as well as the GP practice. So don't just sit back and think it's going to be done for you, ladies and gents. Honestly, it's not. And if you don't do it, then you can bet your bottom dollar pharmacy next door or other pharmacies around that area will start seeking, let's try to get more business in. Let's be active. Let's be proactively finding more business by highlighting to patients, by highlighting to GP surgeries that yes, we can. And we can assure that anytime you send a patient in who is appropriate for these pharmacy first services, that we will have someone on the ground that will provide that training and provide that provision of care. Be that person, okay? Otherwise, if you don't do it, if you snooze, you lose effectively. And that's what some of the top tips I've learned so far in the couple of weeks that I've been in post as a PCN engagement lead. So I guess from the barriers point of view, okay, we need to address what are the barriers currently, and sometimes it could be trust in patients, trust in the parents who are coming in, because in their mind's eye, a pharmacist and a pharmacy team is pharmacists and pharmacy teams, and traditionally we are the packaged goods providers, right? That's a mindset change that we need to start moving away from. We're not just packaged goods providers. We do not sell product now. We sell health. Okay, so we need to change that mindset in our communities that use our services. And the only way we can do that is, you know, if you've got Timpa Health, or if you've got a fantastic core member of team who's been brought and bred within that sort of environment through skills for pharmacy, for example, then you can get that sort of capacity and that provision of care. And then more people who do it, the more people who come to you for that, then word spreads quite naturally. We're going to make sure that, no, although this is quite, you know, exciting times, it's still relatively new for us as pharmacists and pharmacy teams, you know, so, you know, be gentle. Don't say yes to everything. Be sure that if you're not able to do it because of either capacity or you're not confident in engaging with it, then you need to address that as part of your CPD. I know whenever any services comes about, and in Lewisham, this was no different. Any services, all the pharmacists and pharmacy teams would say, yeah, I'll do that service. But when it came down to it, only 20% delivered, 80% didn't do anything. Yeah. And we find that even with Pharmacy First, that, you know, everyone's saying, yes, me too, because everyone has a fear of missing out, FOMO. But ultimately, it's not just about putting your hand up, it's about delivering appropriately in a timely fashion and confidently. Remember, it's your GPHC number online. If you mess up or if you do something which you're not confident or competent to do, it's your registration, but also it could be the patient's life at the end of it, okay? We need to also increase our awareness or the awareness of the services that we provide. You know, don't clutter up your pharmacy, but make sure you've got leaflets, you've got, you know, stickers that will help identify potential services for potential individuals. So if you know, if you've got someone with a hearing aid issue who uses hearing aid, who buys batteries from you, and you're providing things like, I don't know, Timpa Health or whatever, you know, say, did you know we provide boom, boom, boom. That's why you're focusing your services towards potential patients who might utilize that, okay? And always have that good customer experience. You guys are amazing at providing that expertise experience to our patients going forward. And that's why they keep coming to you. But loyalty is always dwindling. We don't have those patients that were always loyal to us because of the online. There's a new generation of patients coming through who are digitally aware, utilize information through Google Health, okay? Make sure also from our GP's point of view, they feel confident that you're able to look into someone's ear. They feel confident that you're able to identify rash A versus rash B, that you know the different types of insect bites, okay? That you know what a shingles rash might look like. You might know what impetigo looks like. And by having that sort of assurance in GPs, they will feel more confident in referring their patients to you, because ultimately the patients aren't registered to us, okay? They're registered to the general practice, the GPs, okay? They've got the list of registrants or of patients that they've got. So they feel very like, oh, these are our patients. And what I've found that they feel that as a result of referring patients from GPs to pharmacies, they're automatically taking some form of risk by addressing that patient and directing to them, okay? Now, that risk may be mindset risk because they've actively referred that patient, but it is a big barrier in GP mindsets because they're allowing someone else to take care of their patient. But we've done that so many times. We've taken their blood pressure, we've done AF checks, we've done inhaler checks and all that. So it's nothing any more different, but the stakes are a lot more higher now because of the risk of loss of function, loss of life, or loss of limb. So we need to really address that. And of course, this has been developed, it's been born out of, it's evolved from CPCS, okay? And you guys know, hand on heart, when you wrote down on farm outcomes and gave the information back to the GPs via CPCS, could you say 100% that what you have written is articulate and medically and clinically appropriate, that would allow SNOMED coding from the GP side? And I think this is also where a lot of hesitation has come from the GP side, that they don't know what information is coming out back from them, and in fact they might need to see the patient again because the information that's been written down from the pharmacy side has caused so much ambiguity and so much confusion that potentially it could be a red flag. Thereby, it's actually impacted on the GP appointment systems inappropriately. So we need to start changing our narrative. We need to be more articulated in SNOMED code narrative, and our clinical consultations needs to be of the same value and the same level as that of a GP, as a general practitioner. Because if we're not speaking the same language, then ultimately we're not giving them the assurance that we've seen what we've seen, and this is how we've described it. And I hope that's something that you guys can maybe just reflect upon it for yourselves, how much of the time that when you do these sort of referrals and these reports back to your GP practice, how clinically significant is it? How clinically accurate it is? And what's the narrative that goes behind it? If you were receiving it, if you're a GP, would you be happy with that sort of information? Suki, anything from our colleagues regarding that? Oh, you're on mute. Sorry. Still on mute, yeah. Okay, I can have a look, no problem. So I think, oh, go on.
Sorry, I've come back on. There was one question about locum pharmacists and how do they sign the PGDs and get authorized in advance, if there was any suggestions of that.
So this is a good question. I mean, look, like a responsible pharmacist, if they're able to provide their service, they should be able to sign your PGD. So you'd have like a pharmacy manager or someone like that to direct them towards the PGDs and to sign them off, to say, look, you're coming into these premises with the expectation that you're going to be delivering. Okay, the PGDs are here. Have a sort of like a checklist for your locums to come in, but also utilize your dispensers or your pharmacy manager to direct that person towards the appropriate information. Sometimes you're absolutely right, Lisa, that farm outcomes, the local may not have access to that farm outcomes, which obviously they're there for the day or even for half a day is difficult, but hopefully your dispenser would have access to that farm outcomes, or your pharmacy manager, in order for that to allow that business as usual process to occur. But that's something you have to speak to with your farm outcome account manager. But effectively, they should be able to carry on with the business whilst using the dispenser or the pharmacy manager there to be able to access the key data, the key databases and farm outcomes to allow that to occur. Does that sound all right, Suki?
I thought Mahesh had quite an interesting question, was about expecting us as community pharmacies, and I actually understand where Mahesh is coming from. It was, isn't it much to expect pharmacists to use SNOMED coding when writing up their notes? And I understand where you're coming from there, Mahesh, because we don't know what SNOMED codes GP practices are using because we write our notes in a particular way. But so I think, is there anything that you can use to help us to be able to make our notes more appropriate to be read as SNOMED codes, I suppose, or that's more identifiable? Because I agree with Mahesh, unless you work in the GP world, and I appreciate that you work, Darshan, as a PCN pharmacist, it's very difficult for us as community pharmacists to know how a GP practice is picking up on the notes that we're making.
No, absolutely.
Yeah.
And look, this is new. This is new territory for us. Okay, it's a new exposure, a new experience. What I would say is with this with the aspect of pharmacy first is that we can get these SNOMED codes quite relatively easily by Googling them, but there are some other platforms out there, and our last sponsor prior to this one, Demdex, they provided a really good sort of platform where individuals who are going through their consultations, they're able to pick the correct phrase, which is linked to a SNOMED code, onto a sort of like dashboard, and then they could copy and paste it and then superimpose it onto farm outcomes. And this really helped keep you guys safe. It also addressed the aspect of clinical governance and clinical safety and ensuring that patient has been safety netting in their consultation. So I think, things like that. But once you get used to these sort of words and phrases in terms of like, both negative and positive connotations, you're able to then build those narrative and then build that assurance for that individual who are receiving it from the GP side. I know, Mesh is saying we are the too much. I know. But Mesh, if we don't, and I totally agree with you saying, for the value that we're getting for each consultation, we've got to put the appropriate amount of time in it. But like anything, if we don't start practicing it from an earlier part, it will get lost in translation. And once it gets lost in translation, you're losing the risk of communication between yourself and the people that you're communicating with, your GP practice. And ultimately, if we're not writing the same sort of narrative, which is clinically articulate and clinically valid, then effectively we might be missing the point and not raising the awareness for that patient to be seen if the referral is required afterwards.
I would say to Mahesh, I understand your frustration because I feel the same in a lot of the situations, but it's really important that the evidence that we're putting down in our pharmacy first consultations really demonstrates that we are clinicians. And even if you don't get to use all the SNOMED codes, which I understand is really difficult to even remember, we've got enough going on. You've got your dispenser asking you one question from one side. You've got a patient waiting at the counter wanting to speak to you about something else. You haven't had your lunch. You haven't been to the loo. All of these things happening at once. But I have actually used DemDX as a platform in order to help me just put the whole consultation in. It asks exactly the same questions that your gateway questions would be. And all I do is copy and paste it and put it into my pharma outcomes notes. I basically open both pages at the same time. And it's not, it does get cumbersome if you are trying to remember how to set out your notes in a more appropriate way. And this system, DemX, has actually been used for A&E departments where, you've got different practitioners that haven't got time, who are very time poor, very similar to us, under those pressures to have to put notes in, which makes the GP, makes those higher up in Department of Health look at our notes and look at our evidence as something that's coming from real clinicians. And I think that's the battle that we're trying to fight. We're trying to crack that door open and say we are clinicians and value us as clinicians. So I suppose articulating it that way is really important. And I absolutely understand your frustration, Mahesh. I really do.
And so Suki, there's a risk here, right? There's a real risk because, like Helen from Timber Health said, we can provide these services, okay, that traditionally audiology were providing, okay. So what's the difference of what we're doing right now that physician associates can't be doing right now? And this article came out quite recently, like last month, and basically the RCGP was saying Pharmacy First is a wonderful starting point for our PAs to improve their scope of practice. So they're already sniffing on the area of work that we're doing currently. And if we don't do it, or if we don't do it to a point where it's clinically acceptable or it's clinically safe, then they'll find someone else to potentially do it. And you know, and I know, the GPs and PAs, there's been a massive issue in the UK about physician associates in terms of their clinical safety. So they're trying to find these guys a position, a job, a role, and they feel that Pharmacy First would be the best way, because then they can take the money from pharmacy pot into the GP pot. Yeah, so any qualified provider, and we've had this loads of times before, we mustn't let this service go away. And if we do it right, this is just the beginning, ladies and gents. Honestly, this is going to evolve into so many beautiful long-term conditions. I'll just tell you some quick projects that I'm doing. I'm doing a respiratory project of how we can escalate the use of air and MART and a brown inhaler in the community pharmacy using your community pharmacist IP provision. We're utilizing Benicol in the community in how we can help patients reduce the amount of cardiovascular disease on top of what they're doing with statins and whatnot. And we're utilizing digital enablers like this dongle that you can put on the blue inhaler to raise awareness that patients may be using the blue inhaler more than they would do. So, this is just like small little projects here and there. Get involved with the projects, get involved with your, different organizations to do something different, because it'll be definitely proof in the pudding, and we can evolve from Pharmacy First going to Pharmacy Forward. And I guess, we've spoke about we need to build trust, we need to build relationship, but above all, we need to build confidence in our GPs that we can deliver and keep our patients safe and healthy in the community going forward. Again, copy and paste from Community Pharmacy England. Don't reinvent the wheel when there's some fantastic resources already out there. And I use this resource. I copied and pasted from the Leicester and Rutland LPC, and they've got a beautiful one-pager. And this is the one I use when I go to the different surgeries and the reception teams. Print it out in color copy and say, look, this is what you need to do. The greens are the good, the reds are the bad, and we need to ensure that anyone in the green who's appropriate and not in the red, let's get them signed out to Pharmacy First for the local pharmacy to be able to engage with that patient. Okay. So, and there are loads of resources, and I think they've revamped the resource material, haven't they, Suki, in Community Pharmacy England to meet the needs. But it's only as good as what you use it for. If you use it, if you don't use it, it's not going to be done for you, because you're not going to reach your local population to the level that you want it to. So I guess from my top tips about engagement, okay, make sure from when you're looking at your team, okay, engage your whole team. Make sure it's not just the pharmacist, it's not just the pharmacy manager or the dispenser, but also, you might have a technician, you might have healthcare, well, you would have healthcare assistants, you'd have a trainee pharmacist, you might have a trainee pre-reg, a trainee pharmacy technician, so please utilize everyone singing from the same hymn sheet, and if they engage with other people, engage with patients, engage with the public, that they're actually reinforcing that, we can deliver, this is what we do. Did you know that we can provide, we can check in your child's ear to check if they've got a risk of infection, so bring them down. And having that sort of, over-the-counter talks makes a big difference. Make sure you're always ready to start of the day, 9 o'clock in the morning when your pharmacy door opens, be ready for it, Make sure you're always checking your pharma outcomes to see if there's any referrals coming through, at least twice a day, morning time and afternoon time, as a rule of thumb. Because if you don't check it and you miss out, then you're only going to add fuel to the confidence issues that maybe GPs and surgeries might have. And like Suki said, we got to make every contact count, because if you don't talk to people over the counter, oh, did you know, then they will never get to know. And especially if you're near schools or nurseries and such, Go out there, go to your local schools, go out to local nurseries, put down your pamphlets, speak to the teachers, speak to the school nurse, and say, this is what we can do. Maybe let your parents know, maybe let the individuals know, because they might just do your bulletins for you. From an operational point of view, like we said about checking your farm outcomes twice a day, make sure you have an appointment diary at hand dedicated for this particular service in terms of who's on site, who's on duty, and who's proficient to provide that particular delivery. Make sure as part of your audit trail, you have a tally chart of how many engagements you've done on that day, on that week, so that it tallies out with the MYS consultation number. So you're being paid for the activity you're doing. The last thing you want to do is, have blood, sweat, and tears and find that you're being shortchanged because it's not being recorded properly. And that happened, for the first few months early on. A lot of pharmacies got shortchanged. Did you get shortchanged at all, Suki, in your pharmacy in the first few months of Pharmacy First?
I think we found that we were struggling with different platforms. So we were using two platforms, and it was basically what was the quickest one and easy to engage with. And that took a bit of time. I'd say our first month we really did struggle. But one point going back to what you were saying about barriers, I found in the first couple of months, speaking to every single person that had a prescription prescribed by their GP that could have been done by one of my members of pharmacy teams, in terms of every single woman that came with a script for nitrofurantoin, uncomplicated UTI. When I've given it out, I've said, you do know you could have just come straight here and not waited for your appointment. And they're surprised to know. Or, oh, you've got a prescription for phenoxymethyl penicillin. You do know you could have just come straight here and had it straight away. I would have done the consultation. You wouldn't have had to wait on the phone, or you could have done this, and you could have. And for every single one of those 7 conditions, our team made it an active point of care that we would actually say that to every single patient that was within those inclusion criteria, for all the 5-year-olds and all the children with the earaches and things. It just became part of the dialogue that we had. And I feel that really helped with the awareness, because don't forget there is self-referral. And if the patient knows that they come to you first, they can bypass that waiting for that GP referral, which is one of our barriers and where we feel really frustrated. And our unique selling point is we have point of contact with those patients. We can tell them what we're doing, and they will remember that time and time again.
Absolutely. And that's so important, like, having that narrative going forward. Yeah. When you're looking at, like we said, with GP engagement, just quickly summarize, make sure that they understand the 7 clinical pathways. Make sure that the new staff do come and sit inside with you at the surgery, in the pharmacy, because that way they can understand the service much more better, and you've got their undivided attention. And also utilize the LLR, LPC one-pager, attend PPG meetings, attend clinical meetings, okay, and utilize the resources effectively to signpost and highlight. And one of the things I found very useful when I go to these PPG meetings for my pharmacy is that the health watch guys, who are the big advocates for our public and people who use health resources in the community and primary care, they will be your advocates. So make sure you utilize and link in with Health Watch going forward. Okay. Other things you could do as well from a peer support point of view, and you've got your LPC place teams, you've got your PCN pharmacists as well, because remember, we're all cut from the same cloth and we all got to support each other. Okay. Utilize the resources, not only from Community Pharmacy England, but also check your ICB and, fabulous forums like these where, the NPA have put together, maybe we can have a forum, we can have a little group whereby we can have this active engagement, so then we can have top tips. That's something maybe with Suki and Helen from the NPA might maybe want to consider, so that we can support these individuals going forward, and we can put it on a WhatsApp group. I know not another WhatsApp group, right? But it helps, because this is the constant communication that we have. In fact, I'll tell you something. I've got like something similar to what Timper Health have got. slightly different, not exactly the same, but slightly different. But you can record it, you can have a video, you can have a photograph of someone's ear canal, the tympanic membrane, and so on and so forth. And sometimes I say, look, show my colleague pharmacist, what do you think it looks like? Or they might show it to me. And sometimes having, someone to ask, does it look like what I think it is? Can you see the landscapes and whatnot? Helps with your reassurance that you're doing the right thing for the right person at the right time. So I guess I'm going to now delve into the actual nitty-gritty of it. That was just my preamble. If you have got your phones, do please take a photograph of the QR code, because that way you can give feedback, of course, but also for your certification for today's attendance, okay, and resources online as well, okay. But I'll be putting this back up again for colleagues who may have missed it the first time, all right? So we know our consultation skills. We know we use a Calgary Cambridge. We've learned it from CPCS. We've learned it from CPPE and the RPS. Okay. So please utilize your skill set in how can we initiate these consultations, and use Calgary Cambridge to help gather the relevant information to allow you to make that appropriate diagnosis. One of the things, I know we're all, time constrained, and you think, this is a bit much when I just want to get the information and give the patient the appropriate sort of like therapy or guidance or signposting. But the more we do it, the better we become at it. And this is the basis for all consultations that we can provide, not only for Pharmacy First, but like I said, Pharmacy Forward going forward. It might be about, inhalers. If you're a prescriber and you want to escalate someone's inhaler because they're using the blue one more than 3 times a week, you might want to say, fine, forget the brown one. Let's go into, I don't know, Foster or Symbicort or something. But this is all the basis that you can provide and gather all that information, utilizing it and building trust and confidence in your patient. Don't forget, the golden minute is super vital, because the patient is the expert of their own body, and they will know what they need to tell you. In that first minute of that consultation, they'll give you the opportunity to tell you exactly what their issue is, how long it's been going on for, what they've been feeling, what impact on their life it's had, okay, because it's so pertinent to that patient and it's first in their brain. If you don't give them that golden minute to explore their understanding, the ideas, concerns, expectations, then you're going to miss it out, and you'll have to address it at the end of the consultation, which might inadvertently change your whole sort of treatment plan for that individual. And remember, always have that empathetic look. We are pharmacists and pharmacy teams. We have got the open ears, and we know our community really well, and we have that time for them in our consultation rooms, okay? So always ensure that you provide that, and have that maybe even on a printed sheet. You can Google it and print it down onto a file in order to just have that sort of experience of knowing what to ask, when to ask it, and what else you might need to do for that individual, okay? But this also gives you an idea of red flags and risk factors for that individual early on, because as soon as the patient is opening up to you, they will give you all that sort of concerns that they have quite quickly without you even having to prompt it, okay? It's not just about the words, it's not only about the phrases or what they say, but also look at their communication apart from the verbal. Look at the non-verbal communication, okay? See how they're sitting, are they touching anything? Are they feeling pain? Are they holding on to anything? Are they doing things which normally is not normal for them? And when I say that, it's, for example, a child might be tugging their ear, holding their face, not wanting to engage, not wanting to talk, and basically not feeling very well. And you know what children are like, and especially we'll be seeing a lot of children with certain levels of our service. Children tend to be wanting to explore, wanting to touch things and play around with whatever equipment you've got. So you have that sort of like spider sense that something may not be quite right by seeing what they're doing as well as hearing what they're saying. Okay. Before we do anything in our aspect in terms of looking at that patient or touching the patient, always gain consent. If you don't gain consent, then effectively they've not given you consent for the next step of their pattern and the management. So it's important to have that, always gain consent, okay? So when we're looking at it from our history, and we know from history that 80% of our diagnosis is made by history alone. And this is super, super important, because the history will tell you the vast majority of the things which has happened in terms of what the patient has come in for, or how long it's been going on for, and if it's happened before, any other sort of history that might be pertinent to their presentation, as well as any other therapies that they might have taken, or treatment failure as a result. But very importantly, if it's something which is consistent with the family, or other members of their family have had it, or for example, they've got any sort of practices or any sort of issues which might require referral to a specific clinic, depending on what they present and what they divulge. So 80% of this will be doing from history taking. So this is even without touching your patient going forward. And the other aspect of consultation, which I'd like to share with you, is SBAR. And SBAR is really important, because SBAR is a really strategic, formulated way of displaying and providing education, your thoughts and your perspective to another healthcare professional for whom you are trying to refer that patient to. So, for example, this is used in patients that may be at high risk, may be showing red flags, who may need to be seen by a paramedic or the GP or another healthcare service provider. And if you just use SBAR, and again, you can Google it and download it, okay? It's structured. It gives the person that you're telling an expectation of what that they're going to be receiving, what they need to know, but also reduces communication barriers, because it's very formulaic. And this sort of time, when it's a higher risk patient, you need to be formulaic. You need to be straight to the point and give the necessary information, be it news to score, be it the fact that they might be the child might be drooling, or they might be unable to swallow, or they might be distressed, the 4Ds and such for epiglottitis, very formulaic, so you get straight to the point, okay? So hopefully utilizing that, we're going to kick off with our first session. So far, so good, Suki?
Yeah.
Yeah, wonderful. So we're going to kick off with our first session. We're going to be looking at sore throats. And we know sore throats are really very much the bread and butter for our sort of business and for our patients who come in, because at this time of year it's rife. Okay, it's rife because of changing weather, the impact of cold spells and warm spells, also the viruses that are pertinent within the community, and because we're living in closer quarters and there's such a difference in temperatures when coming in and out, patients tend to get increased risk of these sort of symptoms. So they're always coming in to buy your Strepsils and Diflam and whatnot. But so there's a certain number of individuals who may need to be further addressed and be provided with further therapies, such as antibiotics, if appropriate, going forward. So I'm not going to dwell too much, because you guys know a lot of this, but I will, if there's anyone, obviously this will be beneficial to address, what are our red flags? What are the top things? So we always address the red flags first, because we don't want to be wasting time with the patient for 15, 20 minutes, only to find that we can't do anything and we haven't passed the gateway point. So address your red flags first and foremost. In this case, we know that it's only for adults and children above the age of 5. We're excluding individual pregnant ladies under the age of 16. First thing we need to look out for, how is the patient? Are they systemically well? Okay, and we can utilize the News 2 scoring in order to address this. And we'll be talking about News 2 score very shortly. But specifically for individuals where children might come into play, they might have the signs and symptoms of epiglottitis. And this is where the 4D comes into play, okay? Have they got dysphagia? Have they got dysphonia, okay? Change in voice? Have they got any drooling, or do they have any distress? And this is super important, because if this is the kind of individual that comes into your pharmacy who presenting with these sorts of symptoms, and mom or dad or parent or guardian says, my child's not been able to eat, they're holding the throat, they're having a slight drooling as a result, okay, their voice is slightly changed, okay, don't delay. this needs to go straight to A&E. Okay, so this person needs to be signposted to A&E, or if they can't come out, or for whatever reason they don't have transportation, potentially a 999 call to the pharmacy. Okay, where you then keep them under observation. Okay, and this is as a result of any sort of interference with a person with potential epiglottitis can further preclude and occlude the esophagus, completely causing a blockage, and that person would become very unwell very quickly. So we need to address that very early on. When we're looking at referral mechanisms, like we said earlier, okay, if they don't have any red flags, well, now do they have a sore throat? But before we look at sore throat, because we've eliminated the red flags, what else could it be? Okay, and the clinical pathway here for sore throat mentions that could they potentially have scarlet fever, could they have quinsy, and could they have glandular fever? Okay, these are the top 3 things which they are trying to exclude because they need to be seen by somebody else. It ain't your job. But hold on, what is scarlet fever, what is quinsy, and what is glandular fever? And very briefly, I'll demonstrate each one. So we know with scarlet fever, okay, we get these outbreaks with scarlet fever in the UK. It's a notifiable disease, okay, and this is something that is not your job. You need to, as soon as you see symptoms of malaise, strawberry tongue, fever, okay, these individuals tend to demonstrate the fact that they've got a strawberry tongue by having that, as you can see on the picture. Okay, these individuals need to be referred to the GP for appropriate identification to the local sort of council as a result of it being notifiable, but also appropriate management, utilizing appropriate antibiotics. Okay. And we know with scarlet fever, it's super common with children, especially around the ages of 2 and 8, okay, where they tend to be sharing sippy cups, they tend to be in close proximity, okay, and we know that without the use of antibiotics, these individuals can remain contagious for about 3 weeks, even after the symptoms appear. So these individuals need to be addressed pretty promptly and precluded from going into nurseries and schools if they haven't been appropriately managed initially. Okay, if left, okay, patients can become very weak, clinically unwell. Okay, they can become dehydrated, they won't be able to eat properly, and it also can cause worsening of their symptoms if becomes systemic unwell as well, and this is where individuals can be at risk of becoming having fever, confusion, vomiting, diarrhea, and potentially the risk of having toxic shock syndrome as well if it's not addressed. Okay, now we find that initially, although the symptoms are usually self-limiting and mild, we need to address these individuals so that they're taken out of the population. And GPs tend to use things like azithromycin for duration of 5 days, depending on obviously the patient's weight and age. But like I said, it's a notifiable condition, so it needs to be referred to the GP to make those appropriate notifiable requirements going forward. Quinsy, on the other hand, okay, is something which we'll need to address through is something that can affect individuals from having pain, fever, malaise. It's usually a collection of pus in the peritonsillar area, okay? It usually occurs in young adults, and it usually causes severe pain, dysphagia, okay? These individuals tend to be admitted into hospital because what they would have to do, where you can see the peritonsillar bulge at the back, they would need to drain the abscess and give the individuals IV antibiotics. So again, nothing for you to do, but this person needs to be referred appropriately to A&E or the urgent care center in order to be addressed appropriately. One of the things that we can see when people with quinsies are presented is that they would have an inflammation in that peritonsillar space, causing a movement of the uvula to one side, so you get a deviated uvula. The next one is glandular fever, and we know with glandular fever, also known as kissing disease, it's a viral infection. is caused by the Epstein-Barr virus, and it's usually passed from person to person as a result of close contact, especially things like kissing. So as you can imagine, it occurs quite a lot in students of university age, okay, or slightly older. But it can also be caught by individuals sharing cups and toothbrushes and so on and so forth. Okay, it can take up to maybe several weeks for the symptoms to start developing after a person becomes initially infected with the virus. And that's what the incubation period is, where it starts to reproduce the virus inside the individual before it becomes pertinent and the symptoms are seen. And symptoms that we can see could include things like high fever, fatigue, sore throat. You may get, as you can see on the picture, enlarged lymph glands, okay, around the neck, groin, and armpits, but also ulcerated tonsils at the back. Again, nothing for us to do, not for our intervention. It's not clinically important that we can do anything. It needs to be referred to the GP practice. Okay, and when we have actually then excluded these sort of areas where it could be something common in individuals, but is not in the remit of our clinical pathway, okay, and we've been able to identify them and refer them onwards, we are then left with individuals who could potentially have sore throat that we can address appropriately. And we have a toolkit available called the Fever Pain tool. And Fever Pain is a scoring mechanism that determines the likelihood that the person would have a streptococcal bacterial infection. Therefore, the potential for the need for antibiotic would be more appropriate. So for each of these aspects, you get 1 point, okay, with a maximum score of 5 points, okay? So you get fever, purulence, it's attended quite rapidly, ideally within 3 days of onset. There's also severe inflamed tonsils, but also there's no associated cough or any sort of symptoms of crozia. Okay, so by utilizing the Fever Pain, we can navigate down the clinical pathway to identify patients who have a Fever Pain score of 2 or 3. It's going to be unlikely or low likelihood of having isolated streptococcus. In fact, it's approximately about 34 to 40% likelihood that it is actually a bacterial infection, whereas a Fever Pain score of 4 or 5 is considered to be about 62, 65% likelihood that it is actually a bacterial infection. And this is why we would give individuals with a high Fever Pain score of 4 or 5 more targeted provision of having an antibiotic, if appropriate, for those individuals. But it's super important to know that, although we are looking for bacterial infections, the vast majority of patients with sore throat tend to be viral and hence self-limiting. So it's important that we are able to then identify these individuals and put them in a correct pathway. So from our point of view, when we're looking at healthcare assistance, because it's not just the pharmacist, it's the whole team, look at a patient who's coming into your pharmacy. What do? They go to the sore throat tablets or sore throat medicines, sprays, and so on and so forth. Have some wobblers or have some flyers or have some stickers on there to say, see your pharmacist today, we can check your throat, potentially give you antibiotics or something of that nature, so that it identifies to the patient that there is a service available associated with that particular ailment. So if they come into the pharmacy, they're wanting to buy something, say they might buy Strepsils or a spray, they go to the counter staff, embed in your counter staff the questions that they might want to ask. So here, for example, Mr. Jones, I see you're buying some Strepsils. Okay, I see. Was it for? Oh, it's for your painful throat. Okay. Do you get pain upon swallowing? They say yes. They say no. Oh, do you get any dry, scratchy throat along with it? May I have a look at the back of your throat? And you might just shine a light at the back just to see. Generally, is it red? Generally, and your counter staff can see. Unless they're obviously colorblind, you can't see. But they can't see. Obviously, it looks red. It doesn't look normal. And do they have a mild cough or not? Are they? And you could ask it to the patient. Are any of the glands swollen around your throat? They might say, yeah, I've got a bit of swelling around my throat. I have difficulty a little bit in swallowing as well. They say, well, look, most of these sort of causes of sore throat are viral. Okay, you should get better within a week. Okay, things like, you're taking strepsils, why don't you consider things like paracetamol and ibuprofen along with it, or medicated lozenges or sprays. But if you think that the person might benefit, in front of you with the pharmacist's intervention, to say, hold on there, before you buy anything, why don't you spend a few moments with my pharmacist who'll just go through the history with you to see if you'd be appropriate for something stronger. And that's when you might have patients who have got multiple symptoms associated with their sore throat, like fever, like pus or spots on tonsils, or they might have enlarged tonsils. So utilize your staff. Have your staff there available. Any questions regarding that by any chance? Okay. Oh, you're on mute, sorry.
Sorry, Darshan. I think looking at the questions, there are lots of questions regarding exclusion criteria and the very fine line that you get between them. So things where patients actually, and I think that's a really valid point because I've had it from Lisa, sore throats may develop rapidly, but only attend the pharmacy after 5 days as they couldn't get a GP appointment. Unfortunately, they then may be excluded. Which means that it would be useful to have a more flexible PGD. Don't get me started on the PGDs.
Yeah.
And our need for flexibility and recognizing so many things that we could treat. I don't think that's been unnoticed either, to be fair. And that's really important in our feedback, that those PGDs don't necessarily reflect what we're dealing with every day. But yeah, I agree with that point with Lisa, where there's an opportunity to help, but because our PGDs are so restricted, how would we get round some of these issues that we had? And there was another point earlier as well. Let me just find it. Bear with me. Well, actually, the one point I wanted to ask is this very interesting slide that you put up, Darshan, with the sort of color coding. Is that available anywhere for us to use?
Oh, this particular one?
Yeah.
You can take a photograph of it. It's not available to use. It's just what we've seen in practice. So like when I speak to my counter staff, I don't want to be the only one to identify because I'm mostly at the back or in the consultation room. So this is why it's so important to empower your colleagues to be able to say, oh, hold on, I can help in that, and internally triage patients appropriate for pharmacy first.
Right. Okay.
Yeah. So just speak to your colleagues. But what I would say is early intervention is the best, and trying to get individuals to if they've been waiting for so long to get an appointment with the surgery, then really it's the surgery at that time should be referring, because obviously there's a capacity issue at the GP practice. So we're missing an opportunity there. So this is why education is so important with your reception teams. Okay, doc. So I'm going to move on now because okay. So sinusitis is the next one. Okay, very common again, pretty miserable for anyone suffering. I know I suffer from it, and honestly, it just gives me headaches and everything. But and I'm sure when I get it, Suki, I'll come to your pharmacy. All right, okay. So we have found that a large number of trials around antibiotic treatment for this particular condition, and we are still left, many of us, wondering whether what are we doing for our patients with sinusitis, because we know antibiotic prescribing for sinusitis remains super high, even though the evidence is not there supporting the provision of antibiotics for these individuals. So it's super important that we identify those individuals who would benefit. Why? Because sinusitis is caused by a virus in majority of cases. We know with viruses, self-limiting. We know also it lasts about 2 to 3 weeks. And we know most people will get better without the need for antibiotics. So this is why it's so important to use your target leaflets to prescribe appropriately. However, with sinusitis, acute sinusitis especially, okay, only less than 2% of cases are actually caused by bacterial infection. Okay, 98% is viruses, all right? And even then, antibiotics make very little difference to the duration of the person's symptoms that they're experiencing. Okay, most people will probably get side effects from the antibiotic itself, like diarrhea, nausea, and vomiting, compared to the benefit that you might have to sinusitis. Okay, so we need to make sure that we're seeing the right people and ensuring that patients are getting the right therapy, but ultimately we're addressing their ideas, concerns, expectations in managing it properly, that antibiotics are not always needed. Okay, and here's obviously our red flags. So red flags first: get the patient, if they're not appropriate for the service, signpost them to the right place. Okay, and we're looking at anyone with the periorbital, intraorbital sort of complications, such as that in orbital cellulitis or displaced eyeball or reduced vision. Okay, any individual who might have intracranial complications like the swelling of the frontal head or the frontal bone. Okay, and also signs and symptoms of meningitis or frontal headache or any sort of neurological, focal neurological signs that would preclude them from the service that we've got. And these individuals straight to A&E, not your job, needs to be seen by somebody else. Okay, so sinusitis, for acute sinusitis, our PGD and clinical pathways allow us to be using for adults and children above the age of 12, and again excludes individuals who are immunocompressed, those with chronic sinusitis, and pregnant women under the age of 16. Okay. And we know between acute and chronic tends to be those individuals who have had symptoms for greater than 12 weeks. All right. So what does our gateway point tell us? Well, our gateway tells us that we have to find out how long they've had it for, firstly. Okay, if they've had it for less than 10 days, it's unlikely that it could be bacterial. It's more likely to be viral, given the statistic of 98% being viral. So we need to watch and wait. Do not offer antibiotics and explain the natural sort of pathology that it should resolve within 2 to 3 weeks, okay? Always safety net, safety net, safety net, safety net. And when you're writing your clinical narrative, you should be writing what you're saying as part of your safety net in terms of what happens if symptoms get worse? What happens if they become significantly worse? What happens if they're not better after 3 weeks that you mentioned? Okay, or if they become systemically unwell. Okay, so if those situations occur, what will the patient be doing as a result? Okay. Also, as part of your clinical narrative, when you're writing it up, what is the self-care advice? And you're welcome to write headings as well to make it easier for you. Self-care advice, you know, you could do a bit of stimulation. Okay, you can use, you should be able to get able to be better within, say, 3 weeks. It should be quite easily resolved. If not, then obviously then there's something else going on. Okay, but paracetamol, ibuprofen. And there is obviously weak evidence, although some people it does work, some people it doesn't, with using saline douches, saline nasal sprays, as well as decongestants, okay? If, for example, on the other hand, the sinusitis that they are presenting to you has been ongoing for 10 days or more, okay, then we have to look at whether or not they've got more than 2 of the following symptoms, okay? And if they got 2 or more of the following symptoms, then that's where we need to use that shared decision making as to appropriate management for that individual. Those symptoms are: do they have marked deterioration after having an initial mild phase? And this kind of follows the pathology of bacteria reproduction, where they might get a bit better initially because the immune system kicks in, and then all of a sudden it becomes worse. Do they have a fever of greater than 38? Again, immune response towards a pathogen. Do they have any unremitting purulent nasal discharge, which could be large in volume, could be green in color, could be quite thick as well? And also, do they have any sort of localized unilateral pain, okay? Unilateral one side, particularly over the teeth, jaw, or gums, okay? And if there are 2 or more of those, then that's where you might need to consider using a shared decision-making process. If not, then self-care, okay, because it's unlikely to be bacterial-led, okay? So here's the next part of that sort of aspect where we're looking at safety netting, okay? Remember, we write this down as part of our clinical narrative: what to do if it hasn't resolved, what to do if it gets worse, what to do if it carries on persisting, in terms of what would be the next steps for that individual. And again, for our patients who are coming into our pharmacy, okay, our wonderful healthcare assistants, okay, and counter staff really help identify these individuals, because you won't see them as a pharmacist or as a pharmacy technician. Maybe you'll be at the back, you know, beavering away, but maybe your counter staff will do, and they might come in trying to buy some Beconase, or they might buy some Sudafed nasal spray or something. Stop and ask, you know, who's it for? Is it someone above the age of 12? Yes. Okay, what are the symptoms? Well, it's pain, swelling, tenderness. Is it around the cheeks, eyes, forehead? Is there any blocked nose that the patient can be experiencing? Reduced smell? Is there any green, thick, yellow mucus coming through? Is there any sort of sinus headache, any temperature, any toothache? So what are the symptoms from that? And then from the management point of view, well, what have you tried so far? Like we do with our WAM, of course. You know, have you tried any painkillers? Have you used any nasal saline spray or douching for your nose? You know, rest, hydrate. Okay, so when might you want to see the pharmacist? Well, if you get two of the symptoms that we mentioned in terms of temperature, in terms of discharge and so on and so forth, and if you find that you're suffering for more than 10 days without any active improvement, then this is someone that you can internally refer going forward. Wonderful. Suki, any feedback from the colleagues regarding that?
One question I had, to be fair, was what I know you talk about how patients need to be educated about the pathology and that they may not need antibiotics.
Yes.
I know as a pharmacist that a majority of the patients come with the expectations that we can give antibiotics. And how do we get around that question? And how do we avoid getting ourselves stuck in that situation where the patient is expecting us to give antibiotics and we can't meet the antibiotic criteria? I know with the sinusitis you have other options, but
Yes.
how do you deal with that situation, Darshan?
So from my point of view, and I've had that situation where, you know, they're almost coming with a preconceived idea that they're going to get an antibiotic out of you, okay? We can't add issues to antimicrobial resistance because ultimately, you know, these guys, you know, they'll say, oh, the pharmacists are prescribing all these antibiotics. Okay, it's because of them that, you know, this antibiotic doesn't work or that antibiotic doesn't work. We didn't create this issue because it was there much before we started, you know, Pharmacy First. But what I would say is, you know, direct the patient away from you and direct them towards a target sheet that we've got that Community Pharmacy England have produced in line with the RCGP to be able to say, look, this is the issue with sinusitis. Okay, these are the symptoms that you're doing. Let's follow the pathway. It shows that maybe it's more likely to be a viral, okay, and thereby you won't need it. And also saying if you do keep using antibiotics inappropriately, potentially when you do need them, they're not going to work. Okay, be very, very blunt because ultimately you don't have the time to spend to go through that sort of argument. Yeah, and as a clinician, you have to expedite clinical judgment to that patient. And they'll respect you for that. Otherwise, they'll milk you for it.
Yeah, and Mahesh makes a very valid point that a recent report showed that pharmacists recommended antibiotics in 24% of cases
Yes.
versus GPs in 39% of the cases. And I think Mahesh and Darshan, you're right. We've been giving out antibiotics, but we weren't the prescribers giving out those antibiotics. So I think it's a bit unfair to see us as the people that are going to cause antimicrobial resistance when it was there way before we started prescribing.
Absolutely, and because of our nature as we're quite risk adverse, we don't want to be giving out something inappropriately. I think we could use that as a superpower to keep our communities healthy, but also educate them as well. Okie dokie. So nearly there. Okay, so this is our third part, which is a UTI. And wow, look, UTIs are super common, okay? It's a common type of bacterial infection in human beings and frequently result in people coming into the community pharmacies to seek advice to buy over-the-counter cystopurine or any sort of alkalizing agent or anything that could help them reduce that impact, okay? Commonly known as cystitis, okay? It affects both the bladder and the urethra and can spread, if unchecked, if the patient's immunocompromised, significantly to the kidneys. Now, many locations also in the community currently offer diagnosis to treat simple UTIs already in terms of having a dipstick test. This is not common for all pharmacies. So if you are providing it, then, you know, it's an added narrative to your clinical notes and your clinical narrative when you're writing it down. But if you don't have it, then utilize the signs and symptoms that the clinical pathway provides you with. Okay. So in terms of the clinical pathways that we have, okay, again, let's get rid of the higher risk individuals, okay? utilizing, like, is there any risk of serious deterioration or serious illness in that individual? If so, not your job, pass it on, okay? A&E, if there's signs of confusion or deterioration in terms of their sort of how they're presenting to you, okay? If there's any other sort of comorbidities for that individual that puts them at higher risk, we need to get that person seen to earlier on. And this is, again, where News 2 score can come into play. Now, News 2 score is one of the national early warning sort of scores that we use to help identify and standardize the assessment in response to an acute illness. People in A&E or in acute settings like ICU and such utilize this to monitor 6 simple physiological parameters on the form of basis of, and provide that scoring system to find out how unwell that person is in front of them. And we can use that quite easily as well. So I implore you, if you haven't already, print this out, color copy it and put it onto your consultation room, because if you get these individuals who are significantly unwell and you've had to call A&E, they'll ask you what your News 2 score is, and it always helps them to then prioritize how quickly they need to see you. Do they go to that person who could potentially be having a heart attack, or do they go to that person who's got a really high News 2 score and increased risk of sepsis? Okay, so it gives them that sort of confidence. Now, just to give you an alert, like, score 0 is physiologically normal, okay? So anything within that 0 score is what you expect. Anything that's deviated, either side one or the other side, you add in the appropriate point towards. So, for example, if you got a respiration rate of, say, 9 per minute, plus you have got a pulse rate of 111, okay, that would be a score of 1 plus, for example, 2. So that's a News 2 score of 3, for example, okay? So it's an amalgamate of that. And we use these as a way of what total score that they have to aggregate it to impact on that person's physiological response and how quickly they need to be addressed going forward. But if you go back to the actual, if they're not physiologically unwell and they don't require News 2 score, then do they have UTIs? And what are the things that we would need to then address? Have they got the risk of kidney infection, which is pyelonephritis? Okay, and pyelonephritis would be associated with having kidney pain, tenderness, and back under the ribs, any sort of new or different sort of pain that they're getting, or flu-like symptoms, any rigors or chills they might be getting, and also temperatures, anything greater than 37.9 and above, and also any associated nausea. If so, they need to be seen on the same day. There is a GP or out-of-hours service which is operating on that day. Yeah. So we know that, and the example I gave earlier on about, gentleman rocking up to the GP practice wanting someone to see because he's got a UTI, and the fact that he's on the catheter, we know that we've got exclusion criteria, and you can see the exclusion criteria that we've got online. Okay, it's only for women aged between 16 and 64 with suspected lower UTI. Okay, it excludes pregnant women, it excludes individuals who have got catheters, and also individuals who have got recurrent UTI. And when we say, well, Darshan, what's a recurrent UTI? It's individuals with two episodes in the last 6 months or 3 episodes in the last 12 months. Okay, so we need to identify these individuals and say, look, no, you need to be seen by the GP practice. Okay, and this is super important, especially UTI being so common, that our receptionists in GP practices know this specific amendment, because you don't want to be having that sort of ping pong effect of that patient, because then they'll lose faith in the pharmacy and say, oh, the pharmacy can't help me because they said I've had 2 or more in the last 6 months, so they've sent me back again. Why did you send me in the first place? We don't want that. Okay. So when we're utilizing our Calgary-Cambridge provision, okay, what do we want to identify? We want to identify fever, rigors, loin pain, lower back pain. Red flags first, okay? We want to find out, okay, so tell me a bit more about your pain. If they're excluded from the red flags, well, tell me about what point in the pain. You know, why, what happens when you get that pain? When did it occur? When did it start? Okay, how long have you had it for? What's changed? You know, is it something you've occurred before? Okay, and are there any other symptoms that individuals might get? Okay, in terms of vaginal discharge or bleeding, look at what other history that they might have that could impact on your clinical decision making going forward in terms of are they immunosuppressive drugs, have they got HIV/AIDS, do they have diabetes, for example. Okay, and also look at other things which, you know, within the confines of the consultation room, you know, what's their sexual history like, you know, do they smoke, do they drink, do they use recreational drugs going forward. And this helps you take an articulate sort of history for that individuals going forward as to whether or not they still benefit from your intervention. And then I guess, you know, if you haven't got the risk of pyelonephritis and you've excluded that, we want to now exclude for any of the following, such as vaginal discharge, urethritis, which is post-sexual inflammation, post-sexual intercourse. Also individuals who might use irritants in the area. Also looking at any sort of STIs, looking for any risk, symptoms and signs of pregnancy, and also any GU syndrome of menopause for that individual. And like we said, anyone who potentially could be at risk of immunosuppression because of therapy or condition. If they have got this, of course, it's not your job. Refer them on to the appropriate appropriate sort of service available, but you can then start using your SBAR, okay, when you're making either the same day referral or the onward referral, that, you know, what's the situation, what's the background, what's the assessment, and what are your recommendations as to why you're referring them onwards, okay? If they don't meet any of those requirements, okay, now you have to look at what is the likelihood of having a UTI that you can treat as a pharmacist within your practice. And this is where we do that sort of patient assessment, where the key diagnostic symptoms are, do they have any burning pain when passing urine? Do they have passing urine more often than not at night? Or do they have urine which is more cloudier to the naked eye? Okay, if they've got any of those aspects of dysuria, new nocturia, or cloudy urine, okay, depending on the number you've got, the higher the number, the more likelihood that it is of a bacterial origin that would require management and therapy, okay, you would then go down the pathway of shared decision making and saying, you know, what other things they could be doing to help limit it and whether they would like to consider an antibiotic. If they've only got one symptom of the three, then although a UTI is still likely compared to other diagnosis, you know, we have the absence of other information for that individual, so potentially it may not be. So that's why we might need to be seen to other practices like GP, sexual health clinics, that might need to address that patient more better than what you can. And individuals who don't have any of those symptoms, check if they've got urinary frequency, urinary urgency, or any sort of blood in the urine, or any suprapubic pain or tenderness around that area. If they don't, then it's unlikely that they've got a UTI. So self-care, self-management. But if it gets worse, they need to be seen by the GP. Okay, so it gives you a sort of like an expertise in how to navigate that patient going forward in keeping them safe. But remember, you've already passed the point of gateway, okay, already when you're looking at these three symptoms, you know, so this is, you'll get paid anyway, but you're just making sure from your due diligence point of view that the patient is safe and being seen by the appropriate clinician going forward. When we are looking at counseling points, you know, look at the non-obvious stuff, like, you know, apart from the pharmacological therapy, the non-pharmacological sort of interventions we can make, such as, you know, don't use bladder irritants, don't wash soap or anything down there, just use warm luke water. Don't drink caffeine or fizzy drinks, which can exacerbate or irritate. Make sure that individuals are wiping front to back to reduce the risk of E. coli coming from back to front. Making sure that after intercourse they urinate, or post-coital urination, just to reduce the risk of any sort of bacteria that may have come through intercourse. And also avoid bladder holding, because obviously it can increase the risk of infections, and adequate hydration, like we said. Now, there's anecdotal evidence with the use of cranberry juice. Of course, if it's with sugar, then it can exacerbate these things. But having tablets of cranberry tablets may not be a bad thing. But there's conflicting evidence that it may not work or it may work. But it's nothing which is going to be really evidence-based going forward. And when we're looking at from a safety netting point of view for these individuals, if they don't get better after 48 to 72 hours of completing that course, then they need to be referred back to the GP because you can't do anything for them, okay? And if there's any unexpected outcomes, either during the course of antibiotics or straight after, in terms of blood, in terms of rigors, nausea, vomiting, they need to be seen straight away at surgery or NHS 1.5 hours or emergency department. Again, people, when they do come to you, they're going to see your counter staff first, okay? So if they're buying something which highlights to them that this patient may benefit from a consultation with the pharmacist, ask about symptoms, in terms of burning, pain, about the need to produce more urine or more frequently, more nighttime urine if they've noted that the urine looks cloudy. Yeah. And the management as well. And also looking at it from the management side, what else have they done in terms of paracetamol, fluid, self-care, and when would they be referred for our services as from a pharmacist point of view would be all cases who have got moderate to severe symptoms that we mentioned earlier. Any feedback or questions from that? Suki?
So I've got one from Lisa. I suppose it's more of an observation from Lisa. And Lisa says, I have seen many women that are excluded for a range of reasons. I've obtained GP appointments, but as gateway is not met, we don't receive payment. And I can understand that as a common thread of frustration amongst most of us as community pharmacists, doing a consultation and spending time speaking to that patient. And then we get to a point at which, we've had to refer back, but we've spent time and we've spent effort doing that consultation. And unfortunately, we don't get paid for it.
No,
Anyway,
this is it.
Yeah, I have experienced that a lot of the
Yeah.
time, and it's extremely frustrating, I think.
I think our consult and our narrative needs to be really honed in so that we can identify those individuals who not be appropriate, either having a checklist or some sort of way of identifying those sort of key areas that this person is not for us. And if you do that in the first 5 minutes of your consult, then you've only wasted 5 minutes as opposed to having gone through the 15 minutes chat. But that individual may still buy something in terms of to help alleviate the signs and symptoms for that person, with that symptoms that they're getting. So making every contact count. They can still buy cystopurine, they can still buy some paracetamol, and they'll thank you for it because you've tried what you can do within the remit that you have. But yeah, if you're not going to get an outcome from it, you need to address it and identify it much earlier than later on.
Yeah, and I can understand that then we're trying to then help the patient get an appointment with the GP. We spent 15 minutes on it, which I totally get that frustration. I can feel it through the conversation, Lisa, that you're putting through. It is really frustrating trying to help the patient and then you feel like you're not getting that acknowledgement. I completely understand that. Obviously, there are lots of Alison has very kindly put some red flag fact sheets that we've actually got to help make that process a little bit quicker to support your pharmacy first consultation. So I do urge everyone to try and use those resources as much as possible. I know I've laminated them in my pharmacy so that they're there ready, and then after a while you do get used to it, but I do understand it's a lot to get through, and there's a lot of information, to be fair.
Absolutely. I'm going to just quickly go on to the shingles bit because I know time is short, so I don't want to. I respect people's times, but we know when we meet the gateway points for shingles, okay, what are we looking for? We're looking for burning, stabbing, throbbing, intermittent or constant pain, any headaches or photophobia, rashes or lesions, okay, new vesicles that form within 3 to 5 days, and also those individuals which are painful, itchy or tingly, okay. We know that with shingles that doesn't cross midline because it's unilateral, because it goes through a particular nerve ending. okay? And it's more likely, if they've got these aspects, that it's more likely to be shingles as opposed to something else. But if it is something else and they don't meet this criteria, it's not your job to pass them on. So be quite focused, laser guided in your consultation when you're talking to these individuals as to whether or not you can treat or refer. And we know with shingles, okay, if it takes within 72 hours or up to 7 days of the onset or a rash, okay, so we need to review these individuals, okay, at risk. And this differentiation occurs that does it happen within 72 hours of onset of rash, or and if it does, okay, do they meet any of that following criteria, as well as any patient above the age of 50? If they do, then you can proceed. If it's not, then we start looking at the individuals who have had a rash up to 1 week after the onset, okay, and as well as looking at the immunocompressed and severe pain that might be symptomatic for that patient. We also look at all patients aged 70 and above. So it really opens your criteria that we need to manage these and treat these people appropriately and identify them much more sooner than later, okay? So I guess these individuals who would then be appropriate would then be provided for acyclovir. And we know with the acyclovir dose, we've got to give it to them over a period of 5 days, okay? We want to make sure also that if they're not appropriate, then we'd give them an alternative valsaclovir as per the PGD. We know with shingles that, you know, when do we decide not to see them and we need to refer them on, that A, they're systemically unwell, they're pregnant or suspected to be pregnant, okay? They may also have vesicles forming after 7 days of antiviral treatment, which means that that's a treatment failure, they need to be seen by somebody else, or they might be an immunocompetent person who has had a second or recent episode of shingles, so it's reoccurrence, okay? So individuals who also worsen rapidly over a period of time and where pain is inadequately controlled with oral analgesia as well. So those individuals we need to identify pretty promptly in order to make sure that they're seen by the right people at the right time and referring them accordingly. Okay? So to meet the gateway criteria going forward for shingles, okay, specifically, okay, we need to ensure that the early signs are identified, and we note on our clinical narrative that the patient mentioned tingling or painful feeling in an area of the skin, on the torso, and potentially they might have headache or general malaise or feeling unwell. They would have a rash appearing up to 3 days later, or in rare cases, the pain could be without the rash, but usually the rash appears obviously in the chest or tummy area, in the torso area, but can also occur in other areas such as the face, eyes, and genitalia. And normally appears on one side of the body owing to the actual pathology.